All right, ready to dive deep into the GI world. This one is tailored for you based on those GI studies you've been poring over.
The gut is a fascinating place.
It really is, like having a backstage pass to how everything works down there. We've got, let's see, your study guide, that vocab list.
It is a long one.
Feels longer than like a CVS receipt. And some pretty detailed notes, too.
Lots to cover.
So what we'll do is pull out the need-to-know stuff, the aha moments that'll make this all stick.
We'll connect the dots, explain the why.
Love that. Okay, right off the bat, I'm seeing colostomy skills highlighted.
Ah, yes.
And it's a good reminder that knowing how to do things is just as important as the book stuff.
Absolutely.
The guide mentions a healthy stoma should be beefy red. It's a pretty vivid image. Why that color?
It signals good blood flow, healthy tissue. If it were pale or bluish, that'd be a red flag. Circulation problem.
Makes sense. And there's a tip. Empty the colostomy bag when it's half full. Comfort, right? And to prevent leaks.
Comfort's key, of course, but also protecting the skin around the stoma. Emptying regularly prevents leaks, irritation.
Makes sense. Speaking of post-op, the guide says the first sign of bowel function returning is usually flatulence.
Not the most glamorous sign, but a welcome one.
Okay, maybe not dinner table talk, but definitely good to know. Colostomy care really seems to be all about the details.
Oh, absolutely. Hand hygiene, first and foremost. Then meticulous cleaning, the stoma and surrounding skin. And, of course, securing the pouch. No leaks.
So cleanliness is key. Got it. Now, on to some heavy hitters in the GI world. Cirrhosis and hepatitis.
Big topics.
The guide doesn't sugarcoat the link between cirrhosis and alcohol abuse, that's for sure.
Cirrhosis is essentially scarring of the liver, damage that builds up over time. And the liver, well, it's involved in so many bodily functions. When it's compromised, things can go south quickly.
The guide mentions ascites and jaundice, some scary symptoms. Ascites is described as bloating, but what's actually going on inside? And with jaundice, why does the skin and eyes turn yellow?
Okay, so with ascites, the liver isn't functioning properly, so fluid builds up in the abdomen, hence the blooding. And jaundice, that's a buildup of bilirubin, normally processed by the liver, but when the liver struggles, bilirubin builds up, leading to that yellowing.
Wow, it's amazing how interconnected everything is. Then there's encephalopathy, which the guide says comes from too much ammonia in the brain. Why is that a problem?
Well, remember how the liver's like the body's detox center? One of its main jobs is filtering the blood, removing toxins, like ammonia. Cirrhosis disrupts this. Ammonia builds up, can reach the brain. Confusion, disorientation, even coma in severe cases.
That's frightening. The blood tests show some big changes, too. Decreases in white blood cells, red blood cells, platelets, albumin, hemoglobin, and increases in bilirubin, AST, ALT, GGT. It's a lot. What can we learn from these changes?
They're warning signs, showing the liver's having trouble producing proteins, processing waste products. The decrease in albumin, for example, is concerned because it helps with fluid balance. Without enough, you get fluid buildup, like we saw with ascites.
Okay, so blood tests really give a lot of info. The treatments range from draining fluid paracentesis to more complex things like Levine-Denver shunts and TIPS. What are the goals of these treatments?
Relieving symptoms, addressing those underlying issues from cirrhosis. Paracentesis relieves discomfort from ascites. Shunts redirect fluid buildup, improve circulation. TIPS, that stands for transjugular intrahepatic portosystemic shunt, reduces pressure in the portal vein, which can be very dangerous if it gets too high.
So different tools for different problems. Let's switch to hepatitis. The guide mentions those generic flu-like symptoms, but also jaundice, changes in stool and urine color. What makes those specific to hepatitis?
It can be tricky. Those initial symptoms, they often mimic a cold or flu, but jaundice, dark urine, pale stools, those are signals something's up with the liver. And it's key to remember there are different types of hepatitis, A, B, C, and others. They have different modes of transmission, different incubation periods, different long-term consequences.
Right, the guide's chart lays it all out. Hepatitis A and E, contaminated food and water. Traveler's diarrhea comes to mind.
Exactly.
B and C, blood-borne, so safe sex practices according shared needles are crucial. And the incubation periods, they can be surprisingly long.
Weeks for hepatitis A, months for hepatitis B, sometimes before symptoms even show up. That's why prevention is so important.
The guide mentions vaccination, but the dosage is interesting. 2 doses for hepatitis A, 3 for B. Any idea why the difference?
It's how the vaccines work, how the body builds immunity. They stimulate the immune system in slightly different ways. The number of doses needed for long-lasting protection varies. The good news is both vaccines are very effective.
That's reassuring. Okay, we've covered some serious liver conditions, but there's still more to explore. Let's talk about 2 conditions that can really bring the pain: pancreatitis and cholelithiasis.
Or, as most people know them, gallstones.
Gallstones, right? Pancreatitis. The guide describes it, well, kind of unsettlingly. The pancreatic enzymes, they start to digest the lining of the pancreas.
It's a vivid description, but accurate. Those enzymes, powerful stuff, normally they're inactive until they reach the small intestine. But in pancreatitis, they start attacking the pancreas itself. Not a good situation.
That sounds incredibly painful. What causes this self-digestion? The guide mentions gallstones blocking the pancreatic duct, alcohol abuse, injury.
Those can all interfere with the normal flow of those enzymes. Gallstones, they physically block the duct. Alcohol can inflame, damage the pancreas. And injuries, well, they disrupt the structure, the function, like a delicate system thrown into chaos.
And the pain, I've heard it's excruciating. The guide mentions epigastric pain radiating to the back. Why that pattern?
It's all about location, those nerve pathways. The pancreas sits deep in the abdomen, behind the stomach. So pain starts in the upper middle abdomen, the epigastric region, radiates to the back because the pancreas is close to the spine. Those nerves carry the pain signals.
Fascinating, even when it's causing misery. Besides the pain, there's nausea, vomiting, steatorrhea, those fatty stools, and jaundice. How are those connected to the pancreas not functioning properly?
Those enzymes the pancreas makes, they're crucial for breaking down fats, proteins, carbohydrates. When pancreatitis disrupts this, digestion, absorption, they take a hit, a ripple effect.
So it's not just the pancreas itself, but the impact on the whole digestive process. The guide mentions signs of internal bleeding, a gray-bluish internal bruise, specifically Cullen's sign around the belly button and Turner's sign on the sides. What's going on there?
Those are serious. Internal bleeding, a potential complication of pancreatitis. The blood travels, can show up as those bruises. Visual cues healthcare professionals would recognize, take very seriously.
Visual clues are important. The tests show elevated white blood cell count, amylase, and lipase. Why are those key indicators of pancreatitis?
Think of it as the body's alarm bells. White blood cells increase to fight inflammation, infection. Amylase and lipase, those are digestive enzymes from the pancreas. High levels in the blood, that means the pancreas is injured, leaking those enzymes. A chemical signal saying, hey, we've got a problem here.
The lab values paint a picture. And treatment, it aims to give the pancreas a break, right? I see an NG tube mentioned for bowel rest and interventions for gallstones, like ERCP.
You got it. Reduce the workload like the pancreas heel. The NG tube keeps the stomach empty, reduces hormones that trigger pancreatic secretions. ERCP, that's endoscopic retrograde cholangiopancreatography, minimally invasive. Removes gallstones blocking the pancreatic duct, restores normal drainage, eases pressure, lets the inflammation subside.
Clearing the roadblocks so traffic can flow again. I also see H2 receptor agonists to prevent ulcers. Why is that a concern with pancreatitis?
Stress, some medications like steroids can increase ulcer risk. H2 blockers, they reduce stomach acid production, protect the stomach and duodenum lining. It's preventative, protecting those vulnerable areas.
Managing the risk factors. Now, gallstones, cholelithiasis, the risk factors are fascinating. The guide highlights the 4 Fs: fat, fair, 40, fertile, and a history of birth control use. What's the link?
Those 4 Fs, they point to hormones, cholesterol, and gallstone formation. Estrogen, higher in women who are fair, fertile 40, it increases cholesterol levels in bile. Being overweight also contributes to higher cholesterol. And remember, birth control pills, they contain estrogen. Too much cholesterol in bile, it can crystallize, form those gallstones.
Okay, so those are some risk factors to keep in mind. But what's happening in the gallbladder itself? How do these stones actually form?
So picture your gallbladder. It's this little sac that stores bile, which the liver makes to help break down fats. Now, bile has cholesterol, and if there's too much or not enough stuff to keep it dissolved, it can start to crystallize. Over time, these crystals clump, grow into stones, and those stones can cause a lot of trouble.
Like a chemistry experiment gone wrong inside the gallbladder. And why does the pain often come 2-4 hours after eating?
Think about it. After you eat, your gallbladder contracts, releases bile into the small intestine for digestion. But if a gallstone is blocking the cystic duct, the pathway out, that contraction causes pain. The gallbladder is trying to push bile past the obstruction. It's like a traffic jam in your bile duct.
Ouch, that makes sense. Besides the pain, the guide lists other symptoms. Fever, jaundice, steatorrhea, those fatty stools, again, dark urine, indigestion, even flatulence. How are those connected to the gallbladder?
They all come from disruptions in bile flow and fat digestion. Jaundice, that's when the blocked bile duct prevents bilirubin from being excreted, so you get the yellowing of the skin and eyes. Steatorrhea, the fatty stools, happen because without enough bile, those fats aren't being broken down. And the other symptoms, the indigestion, flatulence, they're all part of the digestive upset. The bile's not doing its job.
It's a chain reaction, all starting with that little gallstone, causing a big blockage. Looking at the diagnostic tests, there's elevated bilirubin, ALP, GGT, and white blood cell counts. What do those tell us?
Inflammation and obstruction in the biliary system. The elevated bilirubin, well, we talked about that. It's the blocked bile flow. ALP and GGT, those are enzymes in the liver and bile ducts. Increases mean damage or inflammation there. And the elevated white blood cell count, that's the body's inflammatory response to the gallstone problem.
So the labs give us a roadmap, and the guide lists surgical treatments. ERCP for stones in the common bile duct, sphincterotomy, and cholecystectomy. Can you break those down?
Sure. ERCP, we talked about that earlier. Minimally invasive procedure uses an endoscope to remove stones from the common bile duct. Sphincterotomy, that's a small incision in the sphincter of Oddi, the muscle that controls the bile and pancreatic juice flow. Widening it can help stones pass. And cholecystectomy, that's surgical removal of the gallbladder, often the definitive treatment for recurring gallstones.
So different approaches depending on the situation. And the guide emphasizes, avoid morphine for gallstone treatment. Why is that so important?
Morphine. It's good painkiller, but it can actually make gallstone pain worse. It constricts the sphincter of Oddi, which we just discussed, controls the flow of bile and pancreatic juices. Constricting it traps the stone, increases pressure, makes the pain even worse. So while pain relief is important, morphine's not the right choice here.
Wow, that's counterintuitive. It shows how important it is to understand the mechanisms at play. Okay, we've covered some serious territory, gallstones, pancreatitis, but this deep dive isn't over yet. The guide also covers colon cancer. And a sobering fact, it often develops from polyps.
Right.
So what are polyps exactly, and why should we be concerned?
Polyps, they're abnormal growths in the lining of the colon. Think little bunts, mushrooms protruding from the colon wall. Most are benign, not cancerous, but some, like adenomatous polyps, those can turn into colon cancer over time.
So silent threats, lurping. The symptoms the guide lists, they seem pretty subtle. Changes in bowel habits, blood in the stool, abdominal pain.
Right. Nothing too dramatic, but definitely not something to ignore.
Absolutely not. Those could be early warnings. Any unexplained changes in bowel habits, pain, blood in the stool, you call your doctor.
Exactly. Early detection is key.
Catching it early makes all the difference. The guide talks about colonoscopy and barium enema. How do those help? Visualizing the colon, finding polyps or tumors.
Colonoscopy is the gold standard. A flexible tube with a camera goes into the rectum, the colon. The doctor sees the entire lining, checks for anything unusual. Polyps can be removed during the procedure, biopsies taken to check for cancer. A barium enema, that's an older method, uses contrast, highlights the colon on X-ray. Not as detailed as colonoscopy, but still helpful.
So choosing the right tool for the job. And for treatment, I see polyp removal, colon resection, chemotherapy. What do those involve?
Polyp removal, also called polypectomy, often done during a colonoscopy. Relatively simple, polyps removed with special instruments. Colon resection, that's more extensive, removing part of the colon containing the tumor. And chemotherapy that uses drugs to kill cancer cells that might have spread.
So the approach depends on the stage, how far the cancer has progressed. I'm also seeing pre-op instructions, MPO, nothing by mouth, and a post-op diet, clear liquids, then low fiber, low fat. What's the reasoning there?
The NPO before surgery, that's standard for any procedure involving the digestive tract. Stomach and intestines empty, minimizes complications during anesthesia and surgery. And the post-op diet, it's gradual, lets the bowel heal, resume function without being overwhelmed.
Using back into things, the guide stresses screenings, occult blood tests, colonoscopy. Early detection for colon cancer, why so crucial?
Colon cancer, it often develops slowly over years. The good news is early stage is highly treatable. Screenings can detect, remove polyps before they turn cancerous or catch cancer early. It can really save lives.
A powerful message. Switching gears to oral cancer, the guide defines it as cancers of the tongue, oral cavity, pharynx. Two big risk factors, tobacco and alcohol use. Why such a strong link?
They contain carcinogens, substances that damage cell DNA, increasing the risk of mutations. Those mutations can lead to cancer. Smoking, chewing tobacco, heavy alcohol use, it exposes the cells lining the mouth and throat to these carcinogens. Those areas become vulnerable.
A direct attack on those tissues. The symptoms, persistent mouth sores, difficulty chewing, swallowing, growths on the lips, those might be easy to dismiss, but the guide says don't.
Right. A sore that doesn't heal, persistent pain, difficulty swallowing, any unusual growths, see a doctor. Like colon cancer, early detection is key for successful treatment.
Don't ignore those warning signs. The guide mentions diet adjustments, a soft diet, to help with chewing, swallowing. Why is that important?
Soft diet minimizes irritation, pain, especially after surgery or during treatment, allows patients to get the nutrition they need without aggravating things.
Comfort and nutrition makes sense. Surgically removing cancerous tissue, potentially lymph nodes. Why remove lymph nodes?
To eliminate all cancer cells. Lymph nodes, part of the immune system, they filter lymphatic fluid. Cancer cells can spread to them, so removing them, examining them, helps determine if it's spread, guides further treatment.
Checking for any hidden outposts. Liver cancer now. The guide says most cases are metastatic, meaning they originated elsewhere, and lists risk factors. Cirrhosis, hepatitis B, exposure to toxic chemicals. How do those contribute?
Chronic damage, creating an environment where cancer can take hold. Cirrhosis, scarring of the liver, disrupting function, increasing cancer risk. Hepatitis B, chronic liver inflammation, also raises the odds of mutations, cancer. And toxic chemicals, they can directly damage liver cells, setting the stage.
So, repeated insults to the liver. Surgery, chemotherapy, and radiation are listed as treatments. Can you give a quick overview?
Surgery, when possible, aims to remove the tumor completely. Chemotherapy uses drugs to kill cancer cells either throughout the body or in specific areas. Radiation, high-energy rays to destroy cancer cells or shrink tumors, the best option. It depends on the type of cancer, stage, the patient's overall health.
A multifaceted approach. Before we move on, I want to touch on laparoscopic surgeries. The notes highlight those. What are the advantages?
Minimally invasive. Small incisions, specialized instruments operating through tiny holes instead of a big, open incision. Less pain, faster recovery, smaller scars. It's a game changer for many patients.
Less pain, faster recovery. Who wouldn't want that? Okay, moving on from cancer. We've got a list here. Diverticulosis, IBD, IBS, intestinal obstructions, hernias, peritonitis, hemorrhoids, constipation. Where should we start?
Let's tackle diverticulosis. It's pretty common, especially as people get older. Those little pouches, diverticula, they form in the colon wall, usually harmless. But if they get inflamed, infected, that's diverticulitis. Pain, fever, changes in bowel habits. Interestingly, a high-fiber diet, it's thought to protect against diverticulosis. Lots of fruits, veggies, whole grains.
Fiber's a friend, not a foe. IBD, inflammatory bowel disease, Crohn's disease, ulcerative colitis, chronic conditions, inflammation of the digestive tract.
Exactly. Autoimmune disorders. The body's immune system attacks the digestive tract lining. Crohn's can affect any part, mouth to anus, while ulcerative colitis mainly affects the colon and rectum. Both can cause really difficult symptoms, abdominal pain, diarrhea, bleeding, weight loss.
Being autoimmune conditions, I imagine treatment is complex.
It can be. Medications to suppress the immune system, reduce inflammation, manage symptoms. Sometimes surgery is needed to remove damaged sections of bowel. It's tough to live with, but research is always advancing. More treatment options now than ever.
That's good to hear. Now, IBS, irritable bowel syndrome, everyone's heard of it, but there are a lot of misconceptions, right?
IBS, it's a functional disorder. No visible damage to the digestive tract. But the way the gut muscles contract, the nerve communicate, it's disrupted. Abdominal pain, bloating, gas, constipation, diarrhea.
So not a structural issue, more functional. The guide mentions stress, diet, gut bacteria, all playing a role, but the exact cause.
Still a bit of a mystery. No one-size-fits-all treatment. Managing stress, identifying trigger foods, dietary adjustments, those can make a big difference.
Now, intestinal obstructions, that sounds serious.
It can be. Something blocks the flow of contents through the intestines. A physical blockage, like a tumor, hernia, scar tissue. Or functional, like paralytic ileus, the muscles stop working properly.
So a few different ways that intestinal traffic can get stopped. Hernias, that's when part of an organ pushes through a weak spot in the abdominal wall, right?
Exactly. Like a bulge, a sac, the organ pushes through an opening in the muscle or tissue. Hernias can happen in different areas, but the most common are inguinal hernias in the groin and umbilical hernias around the belly button.
And those can be painful, sometimes need surgery?
Often, yes. Especially if they become incarcerated or strangulated, the tissue gets trapped, blood supply cut off. That's an emergency, needs immediate attention.
That sounds scary. Peritonitis, inflammation of the peritoneum, the lining of the abdominal cavity. What usually causes that?
Usually an infection. A ruptured appendix, perforated bowel, other abdominal organs. It's serious, needs prompt treatment to prevent complications.
An infection spreading in the abdomen. Not good. Hemorrhoids, common, but people don't like talking about them.
Swollen veins in the rectum and anus. Internal, inside the rectum, or external, under the skin. Pain, itching, bleeding, especially during bowel movements.
Often from straining.
Straining is a common cause, yes. Pregnancy, obesity, chronic constipation, those can contribute too. Lots of ways to prevent them. High-fiber diet, plenty of water, regular exercise. Keep things moving.
Make those trips to the bathroom a bit more pleasant. Lastly, constipation. Many people struggle with that.
Infrequent or difficult bowel movements, lots of potential causes, diet, lack of exercise, medications, underlying conditions.
So lifestyle, or sometimes a symptom of something else. We've covered so much. It's amazing how much goes on in our digestive systems, even when everything's working right.
It's an incredible system, and remember, even though we've talked about all these conditions, most of the time our digestive systems work beautifully. Processing food, absorbing nutrients, keeping us healthy.
That's a good reminder. We don't want to cause anxiety. Okay, let's look at this vocab list. Jejunostomy and ileostomy. Sound similar, but different parts of the small intestine, I'm guessing?
You got it. Jejunostomy, an opening in the jejunum, the middle part of the small intestine for feeding or drainage. Ileostomy, an opening in the ileum, the last part for waste products to pass.
Bypassing a portion of the digestive tract when needed. Cholelithiasis. That's a mouthful.
Literally means stone in the salivary gland. A salivary gland stone blocks saliva flow. Pain, swelling.
Tiny stone, big problems. Cholelithiasis, we already talked about that, the gallstones. But lithiasis itself, is that a general term for stone formation?
Yes, stones forming anywhere in the body. Gallbladder, kidneys, salivary glands, you name it.
The umbrella term. Lastly, duodenotomy. Sounds like an incision in the duodenum, first part of the small intestine.
Exactly. A surgical procedure, making an incision to access, treat problems in that area.
Got it. Decoding the medical lingo. Now, these bile duct locations and this tooth diagram, why are these important in the context of the GI system?
The bile duct system, it transports bile, the fluid the liver makes to break down fats. Understanding the anatomy of these ducts, well, it helps us see how gallstones cause problems and how procedures like ERCT work.
Understanding the pathways, how blockages disrupt the flow. What about the tooth diagram? How do teeth fit into the whole digestion picture?
Teeth are crucial for the initial stages of digestion. They break down food mechanically into smaller pieces, increases the surface area, makes digestion more efficient. Problems with teeth, like decay, tooth loss, that can impact chewing, digestion, big time.
Our pearly whites play a role too. We've covered so much, from mouth to colon, common discomforts to serious diseases. A really comprehensive look at this amazing system.
It's been fascinating, and hopefully our listener feels empowered knowing more about their digestive health.
Well said. But we're not quite done yet. After a short break, we'll dive into diagnostic tests, crucial for identifying, treating GI conditions. Stay tuned. We're back and ready to wrap up our GI deep dive. We've talked about all sorts of conditions, but how do we actually know what's going on in there? That's where these diagnostic tests come in.
They're essential. Give us a look inside, help us understand what's causing the problems.
It's like detective work, right? Using tests to gather clues. Let's start with blood tests. We've already touched on specific markers, but how are blood tests used more broadly in GI diagnostics?
Blood tests tell us a lot about the overall health of the digestive system. We can assess liver function, see if there's inflammation, look for signs of infection, even screen for some cancers.
Okay, so putting the pieces together, what about imaging studies? Those actually let us see the organs, right?
Right, detailed pictures, helping us see structural problems, blockages, tumors. X-rays, for example, show the size and shape of organs. Ultrasound, that uses sound waves, good for visualizing the gallbladder, bile ducts. CT scans, cross-sectional views, helpful for the pancreas, intestines. And MRI, that uses magnets and radio waves. Very detailed images, especially for soft tissue. Really helpful for things like Crohn's disease.
So many ways to peek inside. The choice depends on what the doctor's looking for, I imagine.
Exactly. Each technique has its strengths, its limitations. The gastroenterologist chooses the best tool based on the patient, the suspected condition.
Besides blood tests, imaging, are the other procedures commonly used?
Endoscopy, that's a big one, both for diagnosis and treatment. A thin tube with a camera goes into the digestive tract. The doctor can see the lining of the esophagus, stomach, duodenum, colon, rectum.
That's how they get those close-ups. We mentioned ERCP earlier. That's a specialized type of endoscopy, right?
Right, ERCP focuses on the bile ducts, the pancreatic duct. Gallstones, pancreatitis, bile duct tumors.
A specialized tool for a specific area. Can they take biopsies during endoscopy?
Absolutely. Small tissue samples examined under a microscope, check for inflammation, infection, cancer.
Gathering information, taking samples, all through this minimally invasive procedure. What about stool tests, breath tests?
Those two. Stool tests can detect blood, infections, inflammation. Breath tests can help diagnose things like lactose intolerance, bacterial overgrowth in the small intestine. Less invasive than endoscopy, but still give us valuable information.
So many tools to understand what's happening in the gut. But the tests are only as good as the person interpreting them, right?
Of course. A skilled gastroenterologist with the right tools, a deep understanding of the digestive system, that's crucial for an accurate diagnosis and effective treatment plan.
It's a reminder that the human element is so important. Now, we've talked about diagnosis, let's talk about treatment. Lifestyle changes, medications, surgery, a whole range of options.
The goal is always to relieve symptoms, address the cause, improve the patient's quality of life.
And the approach is tailored to each individual, each condition.
Exactly. The specific condition, how severe it is, the patient's overall health, their preferences, it all factors in.
A personalized approach. What about lifestyle changes? Those are often the first step, right?
Often, yes, simple changes can make a big difference. Dietary modifications, increasing fiber for constipation, avoiding trigger foods for IBS. Exercise, regular exercise that helps digestion, reduces stress, which can make digestive issues worse. And hydration, staying hydrated, is crucial for everything to work properly.
The power of healthy habits. What about medications? What are some of the common ones used in gastroenterology?
Lots of different medications targeting different parts of the process. Antacids, proton pump inhibitors, or PPIs, those reduce stomach acid. Good for heartburn, ulcers. Antidiarrheals control diarrhea. Laxatives help with constipation. Antispasmodics, those help reduce the muscle spasms in the digestive tract.
Matching the medication to the problem. And those endoscopic procedures, we talked about ERCP, but what other interventions are there?
Endoscopy can do a lot. Dilate narrowed areas in the esophagus, remove polyps from the stomach, even stop bleeding ulcers. Colonoscopy, we talked about that, removing polyps from the colon, preventing colon cancer.
All of that minimally invasive. When is surgery needed?
Surgery is usually for more complex cases when other treatments haven't worked. Removing a cancerous tumor, repairing a hernia, treating severe inflammatory bowel disease.
A last resort option. And surgical techniques have come a long way, right? Laparoscopic surgery especially.
Absolutely. Quicker recovery, less pain, smaller scars, a big improvement over traditional surgery.
It's remarkable. And it's important to remember the best approach is a collaborative one. Patient and doctor working together.
A partnership based on trust, communication, a shared goal.
Well said. Okay, we've covered a lot in this deep dive. Anatomy, physiology, all sorts of conditions, diagnostic tests, treatments. It's been quite a journey.
It has, and hopefully our listener feels more informed, empowered when it comes to their digestive health.
Me too. I think a key takeaway is that the digestive system, it's not just about, digesting food. It's connected to our overall health, well-being.
Absolutely. Taking care of it is so important.
And beyond the physical side, there's the connection between the gut and our mental and emotional well-being. That gut-brain connection is fascinating. We're not just physical beings, we're emotional, mental beings too. It's all connected.
A great point. The gut-brain connection, it's a constant conversation between the gut and the brain. Stress, anxiety, depression, those can impact gut health, and digestive issues can affect our mood, mental well-being.
A two-way street. Taking care of both our physical and mental health, that's crucial. A great note to end on. We've explored this amazing system, looked at the latest research, emphasized the importance of listening to our bodies.
It's been a pleasure. Hopefully our listener feels equipped to make good choices, support their digestive health.
Absolutely. And remember, taking care of your digestive system, that's self-care. Thanks for joining us on this deep dive into the GI system. We hope you learned something new, feel inspired to take care of your gut. Until next time, keep exploring, keep learning, and keep nourishing that amazing digestive system of yours.